All right. Good evening. Hello, RaySearch Webinars community. I know we are a global community, so probably I should say good evening, good morning, good day, good afternoon, or just a simple hello. So yes, welcome to today's webinar. And today's webinar is about proton arc therapy. And it marks this huge milestone in this specific technique that our experts will cover more. But it also marks the new beginning of RaySearch webinars, I must say. So you probably might notice that we changed a little bit. So now we have more colors, more movement, more excitement, and just more things to invite you over. So now RaySearch webinars became an expertise-driven community, as we say. And the whole idea behind that is just to offer expertise that we do have in our company at RaySearch Laboratories, and we do have very much around us as well. And that comes from our users, from our customers, from our friends, from our collaborations, from inside of our colleagues, and from many brilliant minds that we have around us. So please don't be shy, join our community. Please let our experts that we managed to invite and get to present to you lead you towards more knowledge and more interesting life. So that's the RaySearch webinar. So I hope you will join the journey and you will also enjoy that a lot. So yes, very welcome. But coming back to today's webinar about proton arc therapy, I would like to present to you our moderator for today's webinar. And that is one of our experts, right, that we have at RaySearch Laboratories, and that's Moe Siddiqui. So he's our senior application specialist. Hi, Moe. Uh,
Hello.
hello. That's is joining us all the way from the United States of America. So happy to have you here. And Moe will take it over from me and lead the webinar. So moving forward and present our presenters. Yes, Moe?
Yes, and thank you
Yes.
so much. Wonderful to have everyone available today. And this is really, I'm excited about, and I hope everyone has tons of questions. We'll have a question and answer at the end. And I look forward to today's discussion. We have a couple of great presenters. You might have heard them. And if not, welcome to the first time users of RaySearch as well. We have Erik Engwall. He's going to be our first presenter, and he's going to actually go through his presentation. And so I'm not going to take away his thunder. And he's going to give us his perspective. He's from RaySearch. And then after that, we will have Francesco Fracchioli. And he's going to do his presentation from a clinical perspective. And I think personally, coming from a clinical environment, I truly believe that the expertise comes from the clinic, like yourselves. And I can't imagine not having you involved in this presentation and involved in our journey to, as we say in RaySearch, cure cancer with code. With that, I give to Erik.
Erik, if you would just unmute yourself, everything would be lovely.
Yeah, but I
Yes.
didn't
Hello.
succeed to even share my screen, but I do it a second try. I think it works now.
All good?
Yeah, perfect. So I'm very happy to be here today. It's great to talk about proton arcs. I have been working with it for many years, and now seeing it becoming clinical reality is fantastic. And also being here together with Moe and Francesco is also quite special to me. So actually with Moe, we had a bet in 2018 at PT Cog in Cincinnati about proton arcs. I said by then that 5 years from now, proton arcs will be in clinical use. I lost, and I had to send some bottles of wine to Moe. We met actually Peter Cog in Madrid 2023, and then I delivered those Protos Arcana wine bottles to him. But I was still happy, and I will soon tell you why. And then Francesco, you took our optimization into the clinical reality. So we had a very good collaboration, and it then ended with the first clinical treatments that you will talk a lot about. So it's great being here today together with the two of you. First of all, I wanted to take some steps back and give a brief history of proton arc therapy, with, of course, a little focus also on RaySearch, but also starting from the general community. So the first appearance of proton arcs was in 1995 by Joe Deasy proposing tomotherapy for protons. And then 2 years later, in 1997, the first publication in the Red Journal appeared. Then it was a proton beam on a rotating lung phantom. And if we look at the publications after that, which is shown here, you see that there was quite a long gap. And we had a few publications in 2012, 13, but then it wasn't until 2016 that it took off, and then it's increasing now. So last year we had 19 publications on proton arcs, and so far up to February 4th. So extrapolating, we see where this is going. So in 2016, I started to see that proton arcs got more and more attention. We had quite a few discussions at Peter Cog in Prague about it. And at the plane back, I wrote the first script in RayStation on proton arcs. It was very rudimentary, but it caught my interest. And then a few months later, actually, the first, more sophisticated arc algorithm that was based on scripting in RayStation appeared. That was from the Beaumont group, the Spark algorithm. And that has since then given a lot of attention and also publications. For the next step, then we had this Peter Gok in Cincinnati, where we had this infamous bet, Moe. I said that we wanted to have this something more seriously than just scripting. So we had a master thesis in mathematical optimization in 2019, which was very successful. At the same time, also IBA had started their development for going forward with the arc therapy, and especially their dynamic arc therapy. And we have all the time been very much close to IBA in this development and worked closely together with them. So in 2021, we had our first RayStation built system that could support dynamic arc delivery. It was still a research version, but worked very well together with the IBA machine. In 2022, we had a very successful astrophysics workshop where all different experts from the full community in particle arc therapy met in Lisbon. Then in 2023, that was the time when I lost the bet, but I was still happy, as I said, because at almost the same time we released RayStation 2023B, where we had support for the static arcs for gantry treatments. In 2024, last year, this particle arc therapy status paper appeared that was actually an outcome of the astrophysics workshop. And also later that year, this first clinical treatment with static arcs that Francesco will talk about actually happened. So that was really a major milestone. And then if we look forward, we see in 2026, in the spring next year, we will have full clinical support for dynamic arcs when also the IBA team is ready to go clinical. And we will also support static arcs with a chair. So you see, there has been a lot of development in this area, especially during the past 5 years. So a question is, why do we want this? Why this big search for the proton arcs. So it's really much about the degrees of freedom, that we can utilize all these degrees of freedom of PBS to its max. And with that, there has been a lot of different suggested advantages for the patient and the clinic. We have improved plan quality with dose and LET. We see faster deliveries as one of the advantages. It will become simpler, more close to what we're used to in Linux. And also it has been proposed that it will be more robust than before. So if we look into these 4 points more into detail, we can really see that we can get improved plan quality, especially for head and neck patients. You can see a huge difference. So here on the left, you can see a VMAT plan compared to IMPT that then becomes more conformal. But moving towards Proton Arc, you can really get beautiful dose distributions. Faster deliveries is indeed true if you also make these hardware changes, as, for example, IBA is working on. But the fast deliveries, it will always be a balance between improved plan quality and the fast deliveries. It will be simpler, yes. How about robustness? I say no there. So it is actually so that the arcs will not help with the that now you have intellect spot position from many different directions, and when you have distortions somewhere, it will just drag it away and destroy the dose distribution, which is quite different from having the stacked energy layers that you have in PBS. So therefore, robust optimization is really essential. So it's really good that we have that in the system, but we still need to take quite a lot of care of the interfractional robustness, since that is normally not included in the robust optimization. Another thing is the LET distributions, and they can really come hand in hand, where we no longer have the end of range protons directly stopping in risk organs. And together with LET optimization, you can actually just remove parts of the high LET. And that was actually released, the LET optimization, in the same release 2023B as the first ARC optimization. So now you see some of the benefits. Then, of course, we would like to know really what is a proton arc. So the first you might think of is that it's delivered during rotation. I would actually like to make a slight redefinition there, because it's rather so that you would like to have a multitude of directions, and then the modern optimization techniques will improve the plan quality of these multi-directions. And then we have a fast delivery, so that we contain everything, the arc, in one beam without patient setup between the different directions. So that is what I would say is a real arc. And then if we go more into detail into this question, the answer will actually depend on the patient and the treatment site. So we have different proton gantries. We have the light ion gantries. We have the difference between cyclotrons and synchrotrons. You could also think of having a fixed beam and a chair, and then you also have a gantry, an arc, sorry. And as you might understand, some of the gantries, they will not be able to make the full revolution. And for some sites, you just want to make a partial arc. So it's not that you always take the full revolution. What we see with arcs and with this chair is that actually the arc make the transition to upright treatments easier. And as you will see in Francesco's presentation, they're very complex non-coplanar beams in IMPT are now replaced by a coplanar arc, which is more suitable than for a chair. We have different types of proton arcs. The first one is the static arc that I have mentioned. It's also known as discrete arcs or step and shoot arcs. For the plan, you can see that it's contained in one arc beam. We have a large number of discrete directions, as you see in the animation, and also several energy layers per discrete direction. The dynamic arc, on the other hand, it's delivered during rotation. We still have one arc beam, but to be able to rotate during delivery, we just have one energy layer per discrete direction. And of course, the delivery and rotation characteristics will be important when setting up the plan. In delivery for the static arcs, the gantry or the chair will be stationary, whereas for dynamic arcs, it is moving. Both of them can be delivered in one arc beam. And if we see, for example, the capabilities of the dynamic arc package from IBA, then you can actually do this very swiftly for both types. And having it in one arc beam is already supported by DICOM, so that is easy, and we export it as such. So the dynamic arc in the IBA dynamic arc mode in an example head and neck case could take around 6 minutes. If you do the static arc, it's 8 minutes, so not that far away. It will be slightly slower since you rotate and then stop and deliver your layers. But what you can also do, actually, and what Francesco has been doing, is that you can convert your static arc to a PBS plan. So then it's delivered as multiple PBS beams, and that can be delivered by any machine. That would take much longer, but it could still be worth it because you see so much better dose distributions. For the optimization, we have for the static arc a standard spot and energy layer selection, but then during optimization, we filter out low-weighted energy layers during the spot weight optimization. So you start with a larger number of energy layers, and then you filter them out to a user-defined number. For the dynamic arcs instead, we have built a new spot and energy selection where you analyze the target from all the different directions simultaneously. And then the energy layers are in spots, they are assigned per discrete direction. We have also built this for systems and in close collaboration with IBA, where you have the much higher time for energy switching upwards. So then we sequence it from up to low. And after that, we do the normal spot weight optimization. Here you can see this in a polar plot. So this is the gantry rotation, and then the energy increases out from the center to the border. So if we look at the dynamic arc, which is in blue, you start at an angle with a high energy, and then you rotate and go down in energy, and then you make your upward switch, and then start with a higher energy and then go down. So you get this spiral pattern. And for the static arc, which is in yellow, you instead have these discrete directions and have multiple energy layers per direction. If we look at the different types and look at the different pros and cons with them. So for the optimization time, the dynamic arc is actually slightly faster than the static arc, because here we do the energy selection before the optimization, whereas in the static arc, we do it during the optimization with this energy layer filtering technique. The converted static arc will be the same in optimization time. And for IMPT, the optimization time is obviously much faster because you have fewer layers and fewer spots. Everything will, of course, depend on your settings, but this is something in general. If we look at the delivery time, if we have dynamic arc capabilities, like the one from IBA or similar, then the dynamic arc will be the faster. But as we saw in the previous example, also the static arcs will be very fast if you have this contained in one arc beam. If we convert this to PBS instead, of course, it will be longer, as we saw. For IMPT, we end up somewhere in between now because we need to do all these adjustments in between. But you could also think of in the long term that we get a change of paradigm where the normal IMPT beams are actually converted to one arc beam to reduce delivery time. For plan quality, both arcs are very good. The static arcs tend to be slightly better because the energy layers are selected during the dose-based optimization. And the same applies, of course, for the converted static arcs. IMPT, in general, I mean, it depends on the treatment site and so on, but to generalize, it becomes slightly worse. If we look at dosimetric uncertainty, we have something for that for the dynamic arc, since we rotate during delivery, which is not present for static arcs or IMPT. But this can be steered by the window over which you deliver. And then we see that we need this hardware upgrade to deliver dynamic arcs and these static arcs in one beam. So that is not yet possible. But for the converted static arc and IMPT, of course, I mean, that could be done already now. Seeing these pros and cons, we can also think of that you would take one thing from one of the types of arc and one from the other. So you could also create the hybrid arcs, which is a combination of dynamic and static arcs. So you do it dynamically, and then you can stop and deliver more energy layers from one of the directions. To look into this, if there will be actually a problem with the dosimetric uncertainty, we do, of course, a lot of validation together with IBA on this. And I'm sure that we will come to a good solution here. So we're looking both at single energy layers and patient plans and deliver them during rotation. We already made some successful irradiation of RayStation plans. If we look into the RayStation now framework for PBS arc, we have a new treatment technique that we call pencil beam scanning arc. For the beams now, we have a gantry start and stop angle and also rotation direction, so you recognize that from BMAT. And we have special optimization settings called arc settings for these, where you choose if it's dynamic or static arc. If we look something more into details to the arc settings, so for the dynamic arc, we have a gantry angle spacing, and that's the spacing between discrete directions from where we select the energy layers and spots, and also where we perform the dose computation. And then we have the gantry angle window over which we do the delivery of the spots at the end. For the static arcs, on the other hand, we select a number of discrete directions, and then an initial number of energy layers that will be part of the optimization. And then during the optimization, we filter out energy layers until we reach the final number of energy layers. If we look into some of the optimization approaches for the proton arcs, we see that we have the same objectives as for normal IMPT planning. But actually you need to take some different strategies, as Francesco will talk about. Robust objectives are important since we have this problem with robustness, as I said. What we can do more frequently now with proton arcs is to define avoidance structures so that we don't shoot through some of the regions that we now cannot steer with just selecting a few beam angles. So I would like just to switch to RayStation and show quickly what this looks like. So now I hope you see RayStation. We have the gantry angle here. We see the gantry angle window is at 1 degree. And it's just a Gantt angle spacing on 1 as well. And you see how the energy changes per gantry angle. So this is the gantry angle and then the nominal energy. And we rotate around the patient, changing the energy layers, the spots through the rotation and deliver during rotation. So this is the dynamic arc. And then if we take a look at the static arc, we see instead that here for the gantry angle, we have several energy layers per gantry angle. So here at 90 degrees, we start at 143.6 and then going down in energy. And you can see how this is then transferred around with several energy layers per discrete direction before we move to the next one. Now, if I would like to look at this as a PBS plan, then I can just press this button, convert to PBS. So then it actually converts this plan to a PBS plan. So now instead of an arc plan with 20 directions, we have the PBS plan with 20 different beams and end layers contained in the beams. So this is exactly what Francesco performed in his presentation. So if you got interested into this, we actually now have the possibility to try this functionality in a clinical setting free of charge. So we have this try and buy until December this year. That's a good opportunity, I would say, to try a completely new treatment technique. And finally, I just wanted to highlight 3 papers if you would like to learn more. The first one is this status paper in the Green Journal, which dwells on all the different types of arcs that are. So it's a very good start reference. We have this paper, which is about our dynamic arc optimization, how it works, and all the merits of it. And then finally, this very recent paper with Francesco as the first author about our static arc framework, how it can improve plan quality and head and neck cancer patients, and of course, about the first clinical treatments. So I think that's a great transition to Francesco. Welcome to take over.
Thank you, Erik, and thank you for the introduction. Yeah, this is the summary of our clinical implementation. The first commissioning phase, and then a clinical implementation of proton arc discrete or static proton arc treatments in Proton Therapy Centre in Trento. This is a nice picture of our center. Nicer because the first car in this picture is my old car, 1997 Fiat Punto, which I'm quite affectionate to. The relationship with RayStation was quite fruitful during these last years. I remember in 2019 we firstly decided to sign this research agreement that, as I said once, led us to some very important clinical implementation. Maybe none of them were finalized with a publication, but all of them were used in clinical practice, at least in our center. As Erik mentioned, the journey on Proton Arc started in 2022 in Lisbon. I remember this episode where Erik was seated in front of me. I tapped on his shoulder and I said to him, I'm quite skeptical about the Proton Arc because maybe we are comparing them with not the let's say, state-of-the-art head and neck treatments. And as for my experience in our center, we use quite a complicated beam arrangement that led us to reduce a lot the dose out of the target. And so maybe the dose sparing that we can gain with Proton Arcs is not so relevant. But from that moment on, let's say, a sort of challenge started to try to explore this world of ProtonArc. And I'm going to show you through this nice journey that we had here in Trento in the last 3 years to make this clinically available. First of all, I want to highlight that the idea and the approach to the optimization is quite different now, because if you use the same approach that you used with the MFAO, you cannot gain as much as you can with the ProtonArc approach. Then I will show you the implementation of static ProtonArc for head and neck patient, complicated head and neck patient. So I mean bilateral neck and high prescription doses, close to serial organs at risk. And then our first experience with the first patient treated until now, from fall 2024. Well, as Erik said, we are doing the same path we did with photons. We are moving from MFAO, which is quite similar to IMRT, and moving to discrete ProtonArc, which is quite similar to step and shoot in conventional radiotherapy, and we are going to dynamic ProtonArc. In this slide, you can see how much complicated proton therapy plans with MFAO, so multiple field optimized beams, can be during the delivery. In this case, in our clinical practice, the beam arrangement for bilateral head and neck is made of at least 6 beam direction, and since we use the range shifter splitting technique, this 6 beam direction translate into 11 fields. If you consider that for the same direction, you can split the beam with and without the range shifter. And then you move to this approach where you have only one arc and no range shifter ever used, without any couch kick. So the first attempt was to try to mimic the dose, try to be as fair as possible with respect to MFAO plans. So we're starting by using the same cost function to generate our ProtonArc treatment plan. So this is the version 1 where we use the same cost function, and basically we arrived at the same solution. If you look, for example, here in this box plot, is the dose of the parotid glands in our patient cohort was basically unchanged if we change the technique we used. But then we start experiencing that something that needs to be changed in order to gain as much as possible from this new technique. And in our publication, we defined some tips to, let's say, shorten the learning curve for the new users. And what we arrived to was to define a new cost function that was quite focused on the ProtonArc treatment and the optimization and the optimizer for ProtonArc that led us to start gaining what we want to gain with this new technique. And for example, in the comparison between the mean dose to parotid glands, it became more efficient and more efficient, the new technique with respect to the previous state-of-the-art technique, the multiple field optimization. As I said, in the supplementary material that somehow in some publication can be more relevant than the paper itself, maybe more for the clinical implementation of the same technique in another center. We define these tips for the first and the second round of the optimization, where you can find what were the steps that help us to improve the efficiency of our cost function. I'm not saying that this is the solution, but for sure this will shorten the steep part of the learning curve for the new users. So please read it, improve it, and share it, because sharing is the best way to improve as a community. Let's go inside the commissioning phase of this new technique. We selected 10 patients as I said, head and neck patient with dose prescription higher than 66 gray. And what we did basically was to compare them in terms of nominal dose distribution, replanning rate, robustness, as Erik mentioned, LET distribution, NTCP, some of the endpoints of some models, NTCP models, and the entire process from the data transfer from TPS to the OIS, the delivery, and the dosimetric verification of the plans. Just an example for one patient, and then I will show you the results for the entire patient cohort. This is the comparison, the dosimetric comparison of the nominal dose distribution between proton arcs and multiple field optimization plans. The MFO was the one we delivered on the patient. And you can see how much the dose, the medium-low doses outside of the target are spared. Looking at the DVH, for example, the red one is the DVH of the brainstem. So even if both the maximum dose and the mean and low doses are well spared with the proton arc, as it happens for the eyes. Or for this example, the parotids. The parotids are one of the organs, the parallel organs at risk that responded better with the transition of the techniques. Or in this case, the effect on esophagus and temporal lobes that for sure and low doses to cerebral tissue, for sure the risk of toxicity will decrease. And this is the summary in table form of the effect on the dose to the target that was basically statistically unchanged between MFO and proton arcs. And while this is the effect on the organs at risk, two examples I want to highlight here. The brainstem again, and as you can see, the maximum dose is lowered of a mean value of 9.5 gray, and sorry, the mean is lowered of 9.5 gray, while the maximum dose of almost 20 gray on the entire patient cohort. And the other one is the parotids. The parotid glands are quite characteristic because in our group, in our patient cohort that was tested with the proton arc optimization, none of the patient violated the dose limit of the mean dose to the parotids, which was set to 26 gray, while almost half of them were violated by the MFO plans. This means toxicity reduction and acute and late toxicity reduction. Then we compare, after the nominal dose comparison, we compare them also in terms of robustness. Robustness on the CTV, first of all, and the primary organs at risk. As you can see, they were almost the same in terms of robustness comparison. The major difference was in the brainstem. As Erik said, the robustness of the maximum dose to the brainstem seems to be lower than the MFO. But if you look at this graph, the worst case scenario for the proton arcs is still better than the best case scenario in the MFO. Then we also compare the LET distribution, the maximum LET distribution in the cerebral tissue. And I have to highlight the fact that these plans were not optimized also in terms of LET. This is just an LET distribution evaluation, not optimization. So maybe this distribution can be improved, but at the same time, we didn't know worth the LET distribution in cerebral tissue. Then we looked at some endpoints, NTCP endpoints. The one that responded in the best way possible was the risk of xerostomia. That was a reduction on an average reduction in terms of xerostomia of something around 8.5% on average. All of the others were tested, and all of them, in terms of mean value, resulted in sparing in terms of toxicity if you use proton arc treatments, but was not statistically significant. but still the average was lower than MFO. And then we compare them also in terms of the effect of anatomy change during the treatment course. We usually acquire 3 CT per during the treatment course with our CT on red, so with the patient in treatment position. And for 9 out of 10, a replanning was needed for proton arc because of those to the primary organs at risk violation or target uncoverage. The results were not so much different in terms of MFO if you use the MFO. And this means basically that the workflow to control our patient along the treatment course cannot be changed. So our protocol has to be very focused on monitoring the effect of an anatomy change during the treatment course. The last step was to verify if the entire chain, so an end-to-end test, passing through the OIS, if the static proton arc can be delivered, if the dose accuracy was the same as for MFO, and the delivery times. We use this phantom, which is a rotating phantom, can rotate on the same axis of the gantry rotation, and acquisition can be always perpendicular to the beam direction. The matrix PT can be mounted on it, and you can control the phantom remotely. Thanks to the fact that in the TPS you can convert the proton arc into a PBS multiple beam plan, you can deliver actually passing via Mosaic, which is our OIS, and you can deliver them step by step. What we measured was that using a proton arc with 30 beam direction, the gamma analysis gave exactly the same result that we get from MFO. And this confirmed what Erik said, because the dosimetric accuracy did not change coming from passing from MFO to proton arc, because they are static arc. The delivery times was quite large at the time. Then we tested the same plan by re-optimizing them with 20 beam direction instead of 30. The dosimetric result were still very good, and the delivery time was lower than MFO with the beam arrangement that I showed you in the first slide. Also in terms of delivery time, when a head and neck, bilateral head and neck treatment is going to be delivered. So some conclusion on the commissioning phase. Basically, we get the same target coverage, a significant normal tissue sparing when we look at the parallel and some serial organs at risk. We gain the same robustness in terms of also distribution in the organs at risk. In NTCP, systematically, we improve the LET distribution into mainly into tissue in cerebral tissue. The anatomy variation show that you have an higher sensitivity with respect to MFO, but this is a consequence of the improved dose conformality. And in the end, an end-to-end test, we made an end-to-end test, and we proved that it was deliverable and was dosimetrically accurate. We did it in a clinical environment, in a very classic clinical environment. For sure, some work is still necessary, and this have to come from vendor. They have to help the users to improve the workflow in order to shorten the delivery time as much as possible. Let's move to the first clinical application. At the time being, we have treated or we are treating 11 patients. All of them in the head and neck district, apart from the patient 6 here, which is a thymoma case treated in the chest wall. Not all of them are an entire arc. Sometimes, as Erik said, maybe you need a partial arc. For example, for this first 2 patients that were homolateral neck, we need only 180 degrees of rotation. And as you can see, we started with low doses, and now we are moving to high doses, close to the dose that we test in the commissioning phase. I will going to focus only on these 3 cases, which are quite representative of our patient cohort. The first one was a chordoma case, cervical chordoma case, and these are the dose distribution comparison, and this is in terms of DVH. As you can see, and we didn't only improve the dose in terms of sparing of organs at risk, but we also improved the target coverage in this case. And one nice example is this dose sparing in the hippocampi. This patient was also the first pediatric patient treated with proton arcs. And we were able to lower the dose to the hippocampi, which is strictly related to impairment in listening and learning and delayed verbal recall, which is the dose to 40% of the hippocampi volume has to be lower than 7.3 gray. Never reached with the MFO, quite lower than that value with proton arc. At the same time, we reduce a lot the dose in terms of mean dose to the temporal lobe and to the parotid glands. And doing an estimation of the patient-related xerostomia, grade 3 xerostomia, we reduce the NTCP of almost 30%, which is quite a lot. The patient 7, which is another head and neck bilateral case with quite a high dose, 66 gray of prescription. This is the mean dose reduction in the temporal lobe. And while this is the mean dose reduction in the left and right parotid, that again gives a reduction in terms of risk of xerostomia of more than 11%, which in a model-based approach is one of the key to select patients for this kind of treatment. The left parotid here in the patient 8, the second pediatric patient that we treated with this technique led to a reduction of more than 6% in terms of risk of xerostomia. Trying to make a summary of what we gained on this patient by treating them with proton arcs instead of MFO, in terms of this toxicity, we reduced the risk of toxicity on average of 9%, and the maximum reduction was it's something around 29%. And this is another model that we tested, which is the patient-reported moderate or severe loss of taste within 12 weeks from the treatment, that on average reduced the risk almost of 6%. I think that this will be one of the question that will come from the audience, and I will try to answer it already here. In this table, you see, as a function of the angles of the proton arcs, how many cases of replanning we had, which is quite lower if compared to the results of our study. This is mainly because all of these targets are not so close to the optic nerves. That was one of the main cause of replanning in the commissioning phase study. And at the time being, with all of this control CT, we had only one replanning because of anatomy variation. And on the last column, you see the average delivery time in a 2-room facility where the beam need to be shared. The standard deviation of 2 to 5 minutes is because of this, because the beam needs to be shared. And if on the other room you have a patient that take a lot of time for every beam, the delivery time for proton arcs increase. But this is one of the other great achievement that you can reach with the proton arc. If you schedule 2 proton arcs on the 2 gantry rooms and the beam is shared between these 2 gantry rooms, for each beam, let's say on 1 minute for each beam, you have 30 seconds of delivery time and 30 seconds of beam preparation. And you can switch your beam between these 2 phases, and you almost have no impact on the other room during the proton arc. So we are experiencing for this, for example, that if you schedule the patient at the same time in the 2 gantry rooms, the delivery time are not impacted at all. So to drive some conclusion on this clinical implementation, I will say that it's feasible if a complete commissioning is performed. It's feasible even with our current software hardware configuration and many other, I guess, as Erik said. It's crucial to have a fast and reliable offline adaptive workflow. We have quite an automatic adaptive workflow in terms of dose recalculation, just to check if the patient needs to be replanned or reevaluated from point of view of the clinician. The replanning takes more time if needed. The delivery time is still large, but very comparable with 6 nocoplanar fields with range shifter splitting technique. And one of the two remarks I want to do here is that with these plans, the range shifter is not used anymore. So this reduces a lot of problems, like the reduced probability of collision, reduced out of field dose, better lateral penumbra. And one of the things that I did not add here was the fact that in some center, the range shifter is not automatic. So you have to go in, insert manually, and continue with the treatment. In this case, you completely disregard the problem of manually insert the range shifter. And then there is no couch rotation. So generally, you reduce a lot the probability of collision during the treatment. And then from the side of the planning, I guess the more training the training is important, because the paradigm of the optimization phase really changed. I took quite a bit to improve with the collaboration of RayStation on this, to improve the quality of the treatments, because you have to explore how much you can gain with proton arcs. And then I come back to my first slide when I said that I was quite skeptical with Erik during that workshop, and I'm glad we find out that so many beautiful things that can be done with proton arc treatment. Having said that, this is the publication that Erik was referring to, if you want to learn more about this journey. And I want to thank, first of all, the team from RayStation that supported us in this long journey, in long learning curve, and the entire team in the APSS, especially Medical Director Annalisa Triani and Dr. Frank Lor, and Dr. Stefano Laurentini, our coordinator of medical physicists here in Proton Therapy Center. Thank you.
Hi, can you guys hear me? I hope proton arcs. There's a bunch of questions on there, so I was trying to type as fast as I can with all thumbs, and we'll take a few minutes to answer. And I know there were some direct questions to Francesco, and so I'm gonna give him a chance to read these questions and try to answer some of these questions from him. Let me know, Francesco, if you're able to answer a couple of these questions that's out there. I think everyone is really excited about this, and myself too. And as a clinician, I think some of these people are asking, some of our colleagues are asking, delivery time is one of the things that's out there. Does delivery time include gantry rotation time or just purely beam on time? Any thoughts on that, sir?
Yeah, for my answer, all of the delivery time reported here in this presentation were taken from Mosaic. So from the beginning of the first beam till the end of the last beam. This means that includes the gantry rotation and the delivery time. One of the question here was the fact that they were so quite skeptical regarding the 31 minutes of MFO. The 31 minutes come from the beam arrangement I show you, where you have a couch kick of 90 degrees. You have for each direction the range shifter splitting technique, where you have to insert or remove the range shifter and reduce the distance between the isocenter and the range shifter, so to improve the lateral penumbra. So all of these steps takes time, and that 31 minutes is from the first beam to the last beam of an MFO in a 2-room facility where the beam needs also to be shared.
And I think there was another question on the reoptimization for your MFO plans. This came from Mark, a gentleman that I know very well, and he was asking about optimization workflows that you use for ARC plans. Was there a lot of re-optimization that you had to do? Is it possible that you had to new workflows to contribute to the differences in the plans? What did you experience?
You mean re-optimization in case of
maybe body habitus changes? Maybe this is what he's referring to. Maybe body habitus changes, tumor changes.
Yeah, as I showed in the patient cohort used for the commissioning, where the high risk CTV. So for high risk CTV, I mean 70 gray, 74 gray, close to the brainstem and optic nerves. So where you have serial organs at risk, you had a lot of re-optimization because of anatomy changed in the nasal. The filling or empty of the nasal cavity had a large impact on the dose violation to the primary organs at risk. And they were quite, let's say, not robust plan because of the anatomy changes. In our clinical experience, on the other hand, we experience much lower amount of re-optimization because of anatomy change. And I think that this is mainly because we are not at the same level of dose prescription to the high risk CTV, and we are, let's say, far from primary organs at risk like brainstem and optic nerves. I guess that when we will start treating patients with high risk CTV close to the optic nerves, we will experience more re-optimization. I have to say that RayStation helps in this because with the plan adaptation workflow in RayStation, you basically need just to click a continue when you have recreated your adaptation plan. It's quite smooth and fast. For the one patient that we need to readapt, we take, I mean, after the control CT, the fraction, the fraction after that control CT was the first fraction with the new plan. So we readapt in 1 day.
Well, that's good experience to know. That's wonderful. I think there's a question for you, Erik. Can you comment on not using a range filter and how it affects plant quality? If you could minimize proton ranges, will be relatively deep or shallow targets, like head, neck, so on, a potential treatment for spot behavior?
Yeah, sure. So, I mean, this is one of the main benefits. I would say also that you can remove the range shifter. That was also what Francesco showed, that, I mean, now we don't need to use it. And of course, one of the big benefits is that you don't get the broader spots with the scattering in the range shifter. So that is also, I mean, not only logistically that it makes it easier, but also that the quality of the proton beams get much better.
Okay. And I think, Francesco, you're typing about, there was a couple of questions that came in about integral dose or low dose using arc therapy, and how you handle that. I think maybe if you just want to elaborate on any kind of concerns that your clinical team had for that, or maybe Erik or whoever.
Yeah, our experience was that one of the things I was skeptical of was the fact that we're using so many beam entrance, maybe the great added value you have with protons of medium low doses, you are going to lose that value with proton arcs. But again, after a very detailed elaboration of our cost function, and if you ask to the optimizer some sort of request like the dose reduction in the external volume, so the body of the patient. So if you ask the right thing, the optimizer will help you in improving the dose distribution. And what was our experience that in every comparison, the mean low doses with proton arcs was better than MFO until 5 to 7 grays. Below 5-7 grays, you had this switch of the DVH of the body of the patient, where the dose, the very low doses below 5 grays are higher with proton arc instead of MFO. But again, I thought it will be much worse than that, and I'm quite happy with that. Also, our clinical team is quite happy with that.
And I
We
could
have a
also add that, I mean, if you look at all the different publications, it's actually so that, I mean, I would say all of them report a reduced integral dose in different sites. So it's not only in head and neck, but also in other sites.
And I think there's a few other questions from clinical people asking clinical people, also asking Erik as well. One of the questions I think I thought kind of was interesting. I tried to answer it live. What do you think from a general panel here? What sites do you think we can concentrate on? Obviously, the given sites have intracranial makes sense for proton arcs, right? But can we expand this to other sites in the body for proton arcs? I personally feel like we can. For pelvis nodes, I think we can do that. I think cardomas in the spine, I think it would be wonderful to do that. In your experience, from both you guys, do you think other sites are available for proton arcs? I didn't see a limitation.
I agree with you there. Head and neck is certainly the go-to thing where you can really gain parts. And actually, we also need to learn more as a community to see where it's really beneficial. I'm quite positive that it will not be very much better for all sites. So we need to see that and explore that in detail. But certainly there are many sites that will benefit from proton arcs.
Okay, and I think Mark put back another question, Francesco. If you could take a look at his exact question, maybe I misrepresented his initial question. He was asking about the MFO plans. I'll let you take a look at that. And then there was also a question, I think, Erik, for us, converting static arc to PBS. Is delivery automated for angles? Do I need a select entry mosaic during delivery? I think you've answered that though, didn't you?
Yeah, I mean that is actually what is needed to be done and what Francesco did. So that is what they asked for, having a speed up in the delivery. If we want to have this full automated, then we have the full static arc contained in one arc beam. Then you don't need to do that.
Francesco, if you're ready to answer Mark's
Yeah.
question.
Yeah. Okay. The first answer is that we took the MFL plans as they were before the new, let's say, improvement in the cost function definition for the proton arc plan. And I have to say that the same philosophy when we define our cost function for proton arc cannot be applied at the same way with MFO, because, for example, one of the tips to use to improve the quality of your plan in proton arcs is to use the max EOD function with a very low dose value and with a very low weight. If you use this approach with the MFO, you basically you gain something, but you cannot gain the same as you gain with proton arcs because of the improved amount of degrees of freedom that you have with proton arcs. So you are asking for something with a very low dose, with a very low weight, and the optimizer basically can use a much more degrees of freedom to satisfy that request. So
yes, and if I might jump in there,
yeah.
Also, Francesco. Also, I mean, this is a different type of optimization with this energy layer filtering. So we need some new objectives to steer that energy layer filtering, and the max EUD functions with this very low dose level and low weight will really help to steer to select the right energy layers from start. So it's a different type of optimization, and that's also why we need a different set of objectives. And I can say that yes, you cannot reach the same plan quality with a PBS plan with the new strategy like this.
Now, we are 5 minutes over, so I want to respect everyone's time here. I love this panel discussion. There is more questions in there's like 11 questions. What we'll try to do is we'll try to take these questions and answer them directly in some way or form. We had some pre-submitted questions that Francesco and Erik had reviewed. We'd like to maybe just highlight a couple of those predefined questions for you guys, just to give some clarity to that initial onslaught of questions that we received. And also with that, because I feel like this is such a great talk, I hope we can have a panel discussion like this at PTCOG. So if you guys can go out and get your try-and buy, if you can do some research, and we can have a panel discussion at PTCOG just like this, you know, we can do a champagne salute. We like to do that anyway. So we could do a champagne salute for PBS ARC and the and what we can achieve for our patients, which is great quality of care. So I'll let you answer that quick question, Francisco, that the one that you got, and then from there I'll let Morta come in and try to give any kind of insight to what is happening as far as the recordings. I know there were some questions on recordings and how we're going to share it. So with that, Francisco, maybe you can answer a couple of those predefined questions.
Yeah, one of the questions that I received was regarding the fact that this approach, this workflow can be used in every clinic, and I tried to answer during my presentation. The answer is yes, because we didn't make any software or hardware new implementation in our workflow. And I just wanted to highlight that this workflow can be used by anyone at the time being, and if an ABA user with every platform. The problem is that, as I said, is now an automatization process, an automatization problem that needs to be solved. If we can gain something in terms of automatizing some process during the beam load and beam delivery, the static arc in the way they are and in the way already defined can be very competitive with MFAO in terms of delivery time and plant quality for sure.
Okay. And like I said, we have questions out there. We will try to address those questions, right, Morta? We'll try to do the best I can. Actually, I have some questions as well, but I won't take up our time. So I will make sure to ask questions in this form as well. Morta, take it away.
Well, I only have a very easy task left, and that task is to thank you all. So first of all, thank you, Mo, for moderating lovely this session. Thank you to Erik for telling us how did it go in from RaySearch's point of view, and of course to Francesco to give us this valuable experience from the clinical point of view. I think it covered the whole spectrum of what is needed to get that full expertise-driven knowledge. So huge thank you. And then when it comes to everything admin related, yes, let me get you that information. So recording will be available for everyone to see and watch it. It's going to be uploaded on RaySearch's website. We will follow up with an email, so look out for that. That email will include very useful information, including certificates as well, because we're launching certificates for you to share that you've been involved in this expertise-driven community, and then you learn something new, we learn something together, and then we end up leading together what is coming in the future when it comes to the best cancer care possible. So big thank you to everyone again, and then just to get you a little bit more excited and give you a little more hint what's coming up. So stay tuned. This is only the beginning. So it marked the first stop for the RaySearch Webinars rebranded project, but we're not stopping there for sure. So upcoming webinars, we do have this interesting topic, which is artificial intelligence, AI. You heard it everywhere around you. Have you heard it about probably, but where do we stand? So we will open that discussion, and there will be a machine learning department from RaySearch Laboratories giving their point of view, giving their knowledge, how we as the company have been looking into artificial intelligence and how we've been developing solutions that are functional and being used in real life. So stay tuned, that's coming up later in the spring. We'll make sure to communicate that with you as well and invite you to our webinars. So thank you, and that's a wrap.
Thank you, everybody. And from a friend of mine who always ends his emails with, have a proton positive day. So we will see you soon. Hopefully we'll see you in PTCOG. Thank you, both of you, for presenting. It was a pleasure. And I did like the wine, Erik.
Great. Okay. Thank you.
See you guys.
Bye-bye.
Have a great.
Thank you.
Bye-bye.
Thank you. Bye.
Bye.